Welcome to Variations 4, the GI unit. We're covering questions 8 to 10 in this video, really focusing on bowel obstruction. Number 8 asks us to come up with 4 examples of bowel obstruction, 4 causes of non-mechanical bowel obstruction. So what's the difference between mechanical and non-mechanical bowel obstruction would be one way of looking at this question. How would you define the difference between the two in general? Mechanical versus non-mechanical. Mechanical implies a physical force acting upon the bowel. Like, for example, a tumor growing inside the bowel that's blocking the lumen. Non-mechanical implies that there's nothing physically blocking or pushing on the lumen, but that, as we'll see, the lumen has simply stopped in terms of peristalsis. There's no peristalsis, and this causes the obstruction. Let's look at this in more detail by looking at map number 4. So, list 4 causes of mechanical bowel obstruction. Here they are here. And if you look at them closely, neoplasms are abnormal growths like tumors. Adhesions we talked about above, it follows inflammation. We all know what a hernia is, and we all know what twisting is of a segment of bowel. All of these have something in common, and that is they are physical forces acting upon the bowel, physically or mechanically causing obstruction. How we deal with them here is in the circles, and that should be pretty self-explanatory. If we don't deal with them, we end up getting this fluid and gas buildup in the bowel contents, and this causes these symptoms. How do we deal with it? We deal with it with this circle here, these things. I'm going to talk about these things more after we quickly go through non-mechanical, because non-mechanical bowel obstructions are things we see much more commonly on the general surgery ward, and these apply to it. So I'll come back to these points in a minute. First of all, what are some causes of non-mechanical bowel obstruction? Here they're listed here. Abdominal surgery puts the bowel into shock. We all know what meds like morphine, hydromorphone, and anesthetics can do to the bowels. Again, loss of peristalsis. If we have a decreased blood supply, then the tissues don't work properly. Inflammation and spinal fractures all contribute to a loss of peristalsis. This is a non-mechanical obstruction called paralytic ileus. It is the most common form of obstruction, period, that you'll see. I mean, especially post-op. We get a lot of patients coming in with adhesions, which are mechanical obstructions. So that's true. But post-operatively, this is the most common form of obstruction, paralytic ileus. The good news is that most paralytic ileiuses resolve spontaneously without any kind of surgical intervention needed. Within a few days, bowel activity returns. But let's just take a step back here and look at what do you think the symptoms are of paralytic ileus? And of bowel obstruction in general, what do you think some of the symptoms could be? Of bowel obstruction in general, whether it's mechanical or non-mechanical, the symptoms will be very similar. You've got gas and fluid trapped in the stomach. It can't go through parts of the intestine because there's a loss of peristalsis, so you end up with gas and fluid building up in the stomach. It's not a big stretch of the imagination to imagine how uncomfortable that would feel in terms of nausea, vomiting, physical examination would probably cause you to see some distension. Overall state of very much discomfort. If we don't have peristalsis, we don't have fluid absorption, we get a loss of lights and fluids. So how do we deal with it? For some cases of bowel obstruction, we'll need surgery, like we talked about above with lysis of adhesions. Again, most paralytic ileus cases don't need surgery. An NG tube will cover an INP4, but it's a tube that goes down the nose into the stomach. Suction is applied, and air and gastric contents are removed. It will make a huge difference in terms of the comfort level of the patient. The rest of this stuff should be pretty self-explanatory. Bowel rest we've talked about above. Obviously, if there's an obstruction of any kind, it's generally advised that we have some degree of bowel rest. We'll talk a little more about some fine nuances of that point later on. TPN goes hand in hand if the bowel rest is long enough. Where are we in our questions here? So we've covered question 8 for sure. Question 9, we've covered in terms of talking about these areas down here, that if we don't solve the obstruction, what is the problem? Don't forget, as we talked about above, you can actually have a perforation of the bowel causing sepsis and peritonitis. Finally, we're looking at this head-to-toe diagram on 5. And let's see if there's anything that we need to, I'm only going to talk about the things that aren't obvious for bowel obstruction. White blood cells can be high because of trauma in general, surgery. Of course, if there's a perforation, that can cause infection. So there's lots of reasons why white blood cells could be high. Why could hematocrit be high? Can you explain that for a bowel obstruction? If the bowels aren't absorbing fluid, then circulating volume goes down, especially the fluid portion, the water portion goes down. That leaves larger numbers of concentrated red blood cells for every milliequivalent. That would cause hematocrit to go up. Hemoglobin could be down because of surgery or after surgery. Your lights go down because if it's a small bowel obstruction, then you're not absorbing fluids or lights. Why does your BUN go up? Again, if the bowels aren't absorbing fluids, then GFR goes down, BUN and creatinine go up. Do we give laxatives for people who have a bowel obstruction? If so, why? If not, why? We absolutely do not give laxatives for a bowel obstruction. Most laxatives draw fluid into the lumen. That will exacerbate the obstruction and could potentially increase your chances of perforation. Respiratory compensation for the metabolic alkalosis or acidosis. Let me talk about that point in a minute. Here's some of your diagnostics. Some additional points that we've talked about, most of them. So this is the point I'm touching on. This last point here was also put into the questions, in-class question sheet. It's written in a nice paragraph if you prefer that, but the point is here as well. And what's it saying? We could get potentially metabolic alkalosis from an obstruction, because if there's lots of vomiting and we're losing hydrochloric acid, that could cause metabolic alkalosis. Alternatively, if the obstruction is low, the large bowel is not absorbing water, we're getting our lights and fluids, sorry, but we're still losing a large amount of water lower down. If that's, so basically, if the bowel's not bringing enough water into the body is the point I'm trying to make, then we end up with a lower circulating volume, and potentially that could lead to shock. And as you know, a byproduct of decreased perfusion is anaerobic metabolism, which can cause lactic acidosis, which could put us into metabolic acidosis. If this is like Greek to you, then you need to watch the video from the first unit on pH. So bottom line, with an obstruction, it's possible to have alkalosis or acidosis. To be honest with you, it's not generally the hugest concern on the general surgery wards, this pH with obstruction. We usually deal with the obstruction long before it gets to any of this type of thing.